So I think that's about it. We got a minute or two till we get going. I'm sure some other people will be signing on here in a minute, but I'll go ahead and share my screen for the presentation for today. There it is. Can everybody see that now? All right. Good deal.
Coming up good, Mike. All
right. So we're going to do a little different presentation today. Dr. Crawford is part of the OPIC, O-P-H-I-C, the Oklahoma Primary Healthcare Improvement Cooperative. And he and I did this presentation some time ago on harm reduction. And so we'll talk a little bit about that early on. And then Dr. Crawford, towards the middle of the presentation, will talk with you about OPIC and what OPIC might be able to provide. A number of you work with primary care or no primary care providers in your community, and they may be of interest of this. Or if you're working at a federally funded community mental health center that provides primary care, they may be interested in OPIC participation as well. So we're happy to do this. So it'll be a little bit different presentation. Still, we'll deal with alcohol and drugs and their treatment, but we're going to talk about OPIC, and we're talking about harm reduction. And Dr. Crawford may jump in back and forth as we move along, and we'll stop somewhere in the middle for some questions. Then we'll have time for questions at the end. So let's see, something in the chat. All right, Carrie, thanks. So here we go. So this is what we gave back in July, this presentation. The learning objectives are still the same, to talk about harm reduction and how it's an important concept for primary care to practice, and what some tangible harm reduction programs or interventions can be, particularly around opiates. And then we'll talk about OPIC and what they can offer. So, so our objectives are pretty much those. We just mentioned those. I don't have any disclosures or conflicts of interest. I don't know if Dr. Crawford does.
Nope, I don't either,
Good.
Mike.
So we're good there. So harm reduction is a strategy that we use. We use it all the time, and it's to reduce the potential for harm when we know something or it's likely to happen. So, you know, when your kids ride a bicycle, or when you go ride a bicycle out on the street or out on the path, or, you know, down the trail, you probably wear a helmet. And that's harm reduction, because there is a chance, a likelihood that you could fall over, run into something, and hit your head. And so we want to reduce that harm by putting a helmet on you. Same thing with suntan lotion. You're going to go outside. You're going to be outside at the beach. You're going to be working outside. There's a good chance you're going to get sunburned. That's not healthy for you. So we put suntan lotion on. So it's the same kind of principle with substance use, is we can anticipate that if people use substances, there's a likelihood that there could be some harm that could come from using those substances. And so we're going to do something to prevent it. Now, the big one that everybody always, talks about is needle exchange programs. And we're really not talking about needle exchange programs today. We're talking about something that's much, much softer than that, but still saves lives, and it's proven to save lives. And so and that's particularly around opiates. So we can anticipate and educate folks about overdose, and that's harm reduction, and then what to do if, in fact, you have an overdose. And so the naloxone is very important in that. We'll talk about that here in a few minutes. And then there's some things that you can do, like destruction bags. You can use lock boxes. You can use some other kinds of things like that to reduce harm with folks who are likely to have some experience or potentially harmful experience with opiates. So here's our case for today. So I'll read this to you, and then we'll talk a minute here and just see what are the potential harms that could come with a case like this. So Joy's a 62-year-old woman who lives alone. She has a bulging disc in her lower back and takes 50 MME methadone milligram equivalents of opiate medication daily, prescribed by her PCP for pain. So recently, her adult son, Jeff, who's a recovering alcoholic, moved in with Joy. Jeff is legally separated from his wife and has a 7, 9, and 14-year-old children who will be staying with him and his mother 1 weekend per month until the divorce is settled. And Jeff is aware his mother Joy takes opiate pain medication because Joy keeps it in the kitchen cabinet next to the coffee mugs and to her other daily pills. Jeff's been despondent since he moved in with his mother, and he shared with his AA sponsor that he's struggling to maintain his sobriety. So, comments on what might be some potential harms or risk in this case. Rita, you got an idea? Dr. Fink, anybody got a thought? Yeah, Carol.
The children may have access to those pills.
Okay, so the children could be going to the cupboard of the cabinet, could find these pills, accidentally take them. Good. Anybody else got a thought?
Even Jeff.
Huh?
Jeff.
Jeff, okay.
Yeah.
So Jeff is in some kind of recovery and Jeff could get hold of those pills or whatever. Okay. What else? Lenore, you got an idea?
I just agree with everyone else. I think he's going to have to do something with those pills.
All right. So there's several areas of risk and potential harm. So keep those in mind as we go through here, because we will talk about some of those. But primarily, Jeff could get into the pills, or the kids could get into the pills. I don't know. I'm just kind of going out on a limb, maybe, but Jeff might know somebody who's not in recovery who might want those pills too, and Jeff might accidentally let him know that his mother has opiate medication that's easily attained there in the cabinet. So people do that. They'll break into your house to get the medication. So anyway, so here we go. So here's an example, two examples of harm reduction that probably you're aware of. So there's a take back program, and OPIC's been a part of this, and the state has been a part of this. So I'm gonna click on this real quick for you, so you can see. Can you see that? Okay. Can you see the map?
Yeah.
It's a little small, Mike. You may want to hit
Yeah.
that. You may want to
So,
hit that upper right
there we
box
go.
and that may expand it. There you go.
So here you can see, so there's Oklahoma. And so these are take back programs. So these are programs that you could go to if a patient had medication and they wanted to get rid of it. They had old medication, you're not supposed to keep it. So after you have your teeth done, you're not supposed to hang on to it for months on end or years. And so these are places that a person could go to do it. And if you click on one of those, it'll tell you the information. And so you can go and drop those medications off. So that's a handy one. These medication bags, we were at a Dr. Crawford and I were at a seminar not too long ago. We spoke, and they were giving away bags that you could put the medication in, the opiate medication or any other medication, and you could dispose of it. And so here's an example of a company that sells it. And so, but the Department of Mental Health and Substance Abuse Services in Oklahoma, they have them as well. And I think you can get them from them. Medication, they also have medication lockbox or bags. And so that's another. So Granny Joy could have put her medications in a lockbox, and she could have locked that box even if she had it in her cabinet. And that would have put a speed bump or two or a couple of barriers from the kids or anybody else getting in there and pulling the medication off the shelf. And then she could have put it, maybe even put it up where it'd be harder to reach than that. Naloxone has been a lifesaver. People, and with fentanyl, naloxone is even more of a lifesaver. Certainly when people overdose from or take too much or have a bad reaction to opiates, naloxone's come in very handy. But now, even with it's come in handy with fentanyl, because fentanyl shows up in a lot of different kinds of things that it shouldn't show up with. So you may have noticed in the newspaper or in the news. I know there was one case over there at Oklahoma County Jail where they had an inmate and they were going through their pockets or had to restrain him or doing something. And the correctional officers started to get sick, and it was because they were exposed to fentanyl. And so it would be handy. And we were talking with the DA agent who knew a lot about this, and then with somebody from the Attorney General's office. They were saying if your kiddo brings a bag of white powder or some medication looking kind of things or something home that you don't know what they are, you need to really be careful and don't be opening and testing and see what it is, because with the way the fentanyl's coming in and through Oklahoma, you might be tasting some fentanyl. So having some naloxone around makes real sense. And Oklahoma Department of Mental Health and Substance Abuse has this website that you can go to. So you can go right here and it's okay, I'm ready. And if you scroll down, you can go to order naloxone kits. I didn't bring mine today, but you click here and then you just fill out this information as much as you want. And then you submit it. And in about a week to 2 weeks, you get a little box in the mail at your house, and it's got the naloxone spray in it just like this with instructions on how to use it. And I think some of the law enforcement people I were talking to recommended you keep one at home and you keep one in your car. And it's free. So that is really a good resource for us. And there's you can sometimes get it in a pharmacy. Sometimes you have to pay, sometimes you might not, depending on the kind of insurance you have. If your patients are seeing a pain management or family medicine person prescribed ongoing opiate treatment for pain, they probably should have some naloxone at home. So this is a harm reduction strategy that makes a lot of sense, whether it's disposable bags, whether it's turned in, it's locked boxes, and certainly the naloxone is a harm reduction strategy. So here it is. And that's exactly what I got in the mail in a little box was the Narcan, just like that. So something you should think about. So when would you use the naloxone or the Narcan? So anytime anybody's taking that 50 morphine milligram equivalents, MMEs, it's recommended that they have naloxone available. So that would be one area. Anybody who's got any kind of pulmonary or respiratory problems, who's taking opiates, certainly would need some at home, just because the problem of you quit breathing. That's not good. Anybody who's being dually prescribed benzodiazepines and opiates, that's usually contraindicated. But if you see somebody it is, or you know that somebody is, then probably they need the naloxone as well. And anybody who has an alcohol or substance abuse problem. So back to our case. So Joy ought to have some naloxone at home, because she's now going to have her son who has a substance abuse problem. And he's probably been a drinker and had a drinking problem, and he's struggling with that. And he could take some benzodiazepines, or he might start drinking again and detox and do an ambulatory detox or something and be on benzodiazepines. You might think that opiate might just help a little bit more. So Joy should have some around the house as well. And when you have children, that'll be in close contact. So accidental ingestion. So y'all pointed that out pretty quickly. So these would be people that would need, it'd be recommended that they have the naloxone handy. Now, some things we don't think about, and maybe we should think a little bit more about, is people who use synthetic. That would be the fentanyl. So if you know anybody who's using fentanyl or who's a substance abuser, abuses substance like fentanyl, it'd probably be good for them to have that around or have that at home. People who are tapering, so they're coming off or they're reducing their dosage of opiates, and they get it down low. And then something happens, and maybe they have recurrent pain or something happens, and then they go back to the dose they were at, and they can accidentally overdose that way. People who have a history use of stimulants or any methamphetamine, cocaine, or any other illicit substances who are taking, well, any illicit substance, including fentanyl and opiates. So those would be the main ones that relate to having a history of substance abuse problems or mental health problems. Certainly should have some naloxone handy. So, all right. So the other thing that is a harm reduction strategy we've thrown in here is, I'm sure all of you are aware of it, but just in case you're not, is the new comprehensive crisis response program in Oklahoma and in other states as well. And it's the 988 number. So I'll just kind of go over this. We'll go quickly and then go over a little bit more detail, but it includes a helpline and it includes a crisis mobile team, some appointments, follow-up appointments. Those could be outpatient appointments. A nice thing is that it includes technology for law enforcement and other kind of folks that have iPads where they can connect with mental health professionals, if need be, some transportation to a mental health facility, and then hopefully it would be in a facility that's nearby. If you haven't, you can click this link, and I'm not going to play it all for you, but this is the commissioner describing the 988 program. So
Her voice isn't coming up, Mike.
So if you wanted to hear more about that, you can certainly get the presentation, get the web link, and you can listen to the commissioner talk about this. And this web link over here is a much more detailed description. So this is very helpful. So and it's being laid out in Oklahoma. So this is the website, the 988 number that kind of describes it. And let me see if I can a little bit bigger for you. So this describes the zero suicide and the 988 number. And if you click here for resources, you have all kinds of resources. They have a toolkit. Certainly you could use that. They have posters, they have tip cards. They have any number of kind of things to help implement the 988 comprehensive crisis intervention program. So that's certainly a resource for you. So these info sheets, logos, toolkits are all available free of charge, and you can use those. So it should be available now. I think it may be some spottiness in how it's rolled out, but it's for patients and caregivers, and you can be linked. So the comprehensive behavioral health crisis response, I've already mentioned that. And Dr. Crawford will talk about, we go into a little bit at the time, but if you're not aware, then the zero suicide program that the state has developed is also a highly effective and implemental, and something to be implemented in primary care in a local practice to help you manage folks who are having some problems with depression or suicide. Universal screenings, the ESPER approach is part of that. But before I hand it off to Dr. Crawford, I think the thing to note here is this green box that 45% of those dying of suicide saw a primary care physician within a month before their death. And so the sad thing is that people who do suicide do have these kind of problems, do have interaction with healthcare providers within a relatively short period before they actually do something to hurt themselves. So it's an opportunity for primary care and for other providers to work together to try to intervene. So I'm going to hand it over to Dr. Crawford for a bit. You just tell me when you're ready to click the slide forward, and I'll be happy to do that for you.
Thanks, Mike. I appreciate it. Again, I'm Dr. Steve Crawford. I'm a family physician on the faculty at the University of Oklahoma College of Medicine. I've been in practice in Oklahoma for 40 years. And we built a team to help primary care practices in Oklahoma implement guidelines, whether they be heart health, mental health, COVID screening, that type of thing. We've done a variety of projects over the last 7 years to help primary care implement evidence-based guidelines. And we have, over the last several years, helped practices implement the zero suicide or getting naloxone out to their patients that Dr. Brand mentioned, and many of their those that are at risk. We've also done guideline implementation for practices regarding safer opioid prescribing. We call that program Do No Harm. We've also implemented and helped practices implement the SBIRT program in several different venues in primary care, that see adults 18 and above, for those that are seeing adolescents, and for those that are seeking care through some of our free clinics around the state that's affiliated with the Health Alliance for the Uninsured. What we do in our projects, because we have a grant from the Department of Mental Health in these programs, is to provide free in-practice facilitation assistance for the clinicians and their staff. To get many of these programs implemented, it doesn't, you can't just go and give a lecture to a clinician and say, do it, because primary care is actually a fairly complex animal to work in. And you have a lot of demands coming in at you at all times. And to fully implement any of these programs, you need to involve the entire team that a primary care office entails, including the front desk, the people that answer the phones, the check-in folks, the people that take vital signs, the nurses, the staff, clinician staff, all need to be involved together in all of these different programs. And we work with primary care practices around the state to help them implement these particular guidelines. Dr. Brand, if you'll go to the next slide. So again, these are the programs we've done. We also, because of a need, we implemented a online continuing education program called the Do No Harm Continuing Education Program that is available through the Department of Mental Health website. Now, it's taking a 1-month hiatus because we need to re-up the continuing credit, but it's been in existence for the last couple of years. And we've had over 1,500 people go on and take. It's a 6-part or 6-module course that people can get credit, continuing education credit through. And it also allows prescribers to fulfill their yearly requirement regarding the licensure requirement of having 1 hour of continuing education for MDs, PAs, and NPs that may be prescribing controlled dangerous substances. And you can go on to that particular website to look at that. We're also about ready to implement one for our dental colleagues, much shorter in regards to, it's not a 6-module course. It's I think a 3-module course, but it will be implemented for our dental colleague, because they too have to have a year, every 2-year education program to maintain their license in the state of Oklahoma. And unfortunately, dentists, in the past at least, had been a frequent, not overuser necessarily, but they would feel a lot of sympathy for patients they just got finished doing a dental procedure on, and give patients a fairly large prescription of an opiate because they didn't want to have patients, stranded with pain. But what was happening, unfortunately, was that a lot of opioids were left over in medicine cabinets around our state that were then at risk of being misused or accidentally taken by others that weren't aware of the risk associated with those medications. Dr. Brand, if you go to the next slide. Again, you probably are all familiar with what SBIRT is, being in the behavioral health field, but primary care isn't necessarily, and we try to introduce that to them and the whys and wherefores of why we do it. As you all probably know, SBIRT was started as primarily an alcohol misuse screening tool. We've expanded it to use it for not only alcohol, but other substance use disorders, depression, and suicide risk. And we implement this with having the clinicians use a tablet-based screening tool in their waiting room. So when a patient comes in, they can fill it out, use the screening exams, and then if any are positive, then they get the full screen. And then the patient is taken back to the room. The clinician is alerted that there were positives associated with that. And they are then trained to do brief intervention if it's appropriate, or they already have processes in place that we help them set up to do referrals for treatment of substance use, severe depression, or suicidal ideation. We do this through, again, a process where we have what we call an academic detail or a peer-to-peer consultation, essentially kind of mini lecture between the clinician and the other prescribers that describe the process and provide the evidence of why this is important. But then we go in with our practice facilitators who are trained quality improvement clinician or professionals that have gotten training in practice facilitation to implement these guidelines with a broad primary care practice to help them get through all of the barriers that may be there regarding this particular implementation. Again, as noted, it flags patient at risk or severe depression, substance use disorder. It includes a zero suicide prevention program. It also provides a free Cognito online training on interventions, particularly motivational interviewing. And we are recruiting new practices now in this particular program. Dr. Brand, the next slide. Again, we do the same thing with a small number of adolescent practices around the state. I'm not the primary investigator on this. We have a pediatrician at OU that is our PI on this that helped us design this. And those are the particular screening tools we're using for the adolescents. Again, it can be pediatric only or primary care, like a family physician who has a reasonably large pediatric patient panel. And again, we are recruiting practices now for this particular effort. And then if you go to the next slide, the Do No Harm program was implemented actually at the height of the opioid crisis in Oklahoma. Again, this was a program we worked with the Department of Mental Health on to help implement the newer pain and opioid management guidelines for both acute and chronic pain. And it's very consistent with state and federal guidelines. We've actually had we re-looked at the new guidelines that some of you all may be aware of that the CDC came out with. And actually our program was very appropriate for the new guidelines that the CDC has brought out. Again, there's no cost to practices. We initially recruited 40 practices around Oklahoma to do this particular project. We've recruited a couple of new practices recently and are interested in doing others. The little graphic to the right just shows the acronym Do No Harm and why we use that particular, not only is that's the goal of all of medicine, but this particular program is to ensure safer prescribing of opioids. And you can see the particular efforts that we're trying to do with each of those with a nice reminder by an acronym. I won't go over each of those at this time, but the slides I assume will be available if you're interested. Dr. Brand, if you go to the next slide. Again, this is the online training on opioid and pain management. And you can see other, you can see who gets credit for attending these particular programs. Again, this is a no cost. The executive dean has waived all CME fees for people who will be attending this and getting credit through this. Again, as I note, it's on a hiatus for about a month while we re-up the continuing education. It's only when you do these things, you have to do it for 3 years and then you got to re-up it. And we had a little bit of delay getting that re-up, but it is a combined program between the Department of Mental Health and the University of Oklahoma. Next slide. And that's it, I think, Mike. Again, our OFIC is a effort between us, the University of Oklahoma Health Sciences Center, and it is a multi-disciplinary effort. We have physicians, we have public health researchers, medical informatics folks, we have health, behavioral health professionals, and others involved in helping us do this particular effort. And it involves both our Oklahoma City and our Tulsa campus. But our practice facilitators are actually around the state. They're not just based in Oklahoma City or Tulsa, but we have folks that are strategically located around the state to provide support for practices throughout the state.
Very good. So we have plenty of time left. So any questions or comments about harm reduction? Or I think Dr. Crawford and I both be interested if anybody had any ideas or suggestions about how to, we're open for more practices to be involved. So any ideas or suggestions about how to contact primary care practices and maybe engage them. So we've got plenty of time. I'll be interested in Dr. Pink, if you have, I know you've done this in New Mexico and how this may seem similar to or different from what you are involved with in New Mexico. So have plenty of time to discuss any of those kind of things.
I have a question.
Sure.
I'd like to know, what are some ideas or thoughts about how do we get those, like the naloxone kits, to someone like in the case study? I mean, unless her son's in treatment or she knows about it. I mean, if she's already been to the doctor, has already got her medication, and then this happens, how do we get that to her?
If I may, one would be advertising, social media. Now, she may not be somebody in her, I think she's in her 60s, right, Mike?
Yes.
Again, I'm 69, so I'm not a real social media person, but some may be. But that would be one avenue. The other is to make sure that her prescribing physician is aware of a program like this and make sure that they educate their patients on the availability, or even provide the naloxone to be handed out in practices that provide pain medications for their patients, or provide prescriptions of pain medications. The other would be to engage with our pharmacies around the state to encourage our pharmacists to be more proactive. If they know somebody's on an opiate, they're handing out, the medicines. They're getting the prescriptions now sent in electronically by clinicians, prescribers, and then they hand out the medication. The pharmacist could advocate for the patient, and because right now you can give the naloxone without a prescription, and it's a held harmless type of medication type of thing. So it's certainly something that can be advocated for and given out in a variety of different settings. Now, if the son were to, or any of the people in that family were to end up in the ER from an accident or purposeful overdose, then the ER physician should be the advocate to do this. And again, we need to get the word out to our emergency medicine colleagues to make sure that they advocate that naloxone be provided to patients who end up coming in and having and surviving overdose. But even those that unfortunately don't survive, the remaining family members, because of the psychological trauma from a death, can be very substantial, and therefore giving naloxone in that situation could be very helpful. So a variety of avenues could be used.
Sure. I mean, I think also, if you're a behavioral health provider and you were seeing Jeff, or you were seeing Joy, or you were seeing any of the kids in some counseling, and you're able to put two and two together, then it would make a lot of sense to say, let's get on the computer, or let's, you ought to get on the computer and we ought to order you some naloxone, have it sent to your house just in case the kids get into something, just in case something happens. And so, as behavioral health providers, there's nothing that keeps us from being able to facilitate that, that as well. So good question, Carol.
There may be fear in using a medication like this for many people because they think that, one, since it's associated with an opiate, it has a risk like an opiate in regards to use, any type of use. And the important thing to maybe educate people on is that naloxone is actually exceedingly safe. It's not a drug of abuse. If a person isn't overdosing on an opiate, it's not going to do anything and it's not going to cause any harm in its use, whether it be the nasal spray or an injection. If you, for some reason, had an injectable naloxone, it just won't do anything. Now, somebody could respond to naloxone initially, and then that's where the patient, the people responding, if they've used it and a person does respond, if they're on if they've gotten a fairly significant dose of it, they may require another dose soon after to counter the elevated level of opiate in the person's system. And therefore a second dose would be needed. And anytime a person is noted to obviously be down, 911 needs to be called because the patient needs to be taken to a medical facility for evaluation. But again, the use of naloxone, people are fearful of using it because they may be held, they may have said, well, I caused harm. Well, there's Good Samaritan laws that were put into place to protect people in administering naloxone in a good faith effort trying to save someone, just like CPR. If you do a good faith effort in attempting to revive someone who has fallen and become unresponsive.
Yeah. We might mention just kind of how it works. So, you have endogenous opiates, like substances in your system. So when you work out or you do things that make you excited, those endogenous opiates are released and they sit and they provide pleasure. And then when you take fentanyl, you take an opiate, if I understand it right, Dr. Crawford.
Yep.
Those
going down the right path.
those exogenous opiates sit on those receptors and they just kind of put you to sleep and put you to sleep. But the naloxone kind of kicks them off, and then
Right.
the naloxone sits on those receptors. And so sometimes it takes if all those receptors are covered with exogenous opiates, they got to kick a lot of them off to slow or to reverse the effect. So did I get that right?
Yeah, that's true. The opiate effect, there is both endogenous and, as you say, when you take an exogenous opiate, it binds in the same area. And unfortunately, the effect that you're getting from pain relief also bind the area that stimulates breathing. And you don't have to be a substance use abuser to have an overdose happen. It can be just a new event, as it were. And actually, that is an area that's obviously very risky, as somebody that's what's called opioid naive. And because as you use opioids, your brain becomes accustomed or tolerant of increasing doses. And there actually is no maximum dose of an opioid, interestingly, if you can gradually increase and have the patient become tolerant. That's the reason why some people can be walking around and be taking 200 milli equivalents of morphine a day and look totally normal. Whereas if I took 200, you'd have to give me Narcan in about 5 minutes or I'd stop breathing and die, because not on chronic opioids, because the brain becomes tolerant of that. And when you give the Narcan or naloxone, it takes that medicine away. Now, one of the side effects, if somebody is become tolerant of opioids and you give them naloxone, they could have immediate withdrawal symptoms. And that's something to note, but it's obviously a success if you revive them. But then you've got to then get the medical team involved in treating the withdrawal symptoms if somebody has been on opioids for a long time and have an acute withdrawal syndrome.
Yeah. Other thoughts, comments? Lenore, you got anything?
No, not really. It's just, it's hard sometimes to get people to buy into this whole idea of harm
Of harm
reduction.
reduction, you mean?
Yes. It's gotten to be such a political thing, you know?
Mm-hmm.
I really think more people need to be educated about it. You know, they see it as almost as if you're trying to support their habit rather than trying to cure them, you know. It's gotten to be a moral issue, I think, instead of a health issue.
Mm-hmm.
And I think that we need to do more to get this word out about harm reduction.
Mm-hmm.
One of the arguments for using this particular of naloxone is that you can save somebody that then you can work on getting them treatment for their substance use disorder. Whereas if you don't, they're dead and there's no more chance of
Yeah, it's hard to treat somebody who's passed.
yeah, it's hard to treat somebody who's already in the grave.
I know it.
So,
And
the other thing about the naloxone is there are just a lot of unintended overdoses that end in death. School children and also, you know, other folks, like I was mentioning, the folks in the jail who were just, you know, correctional officers who were attending to someone who had fentanyl, high dose of fentanyl in their pocket. It's pretty potent, and so they were getting sick. And you know, there have been other cases where people stop somebody, law enforcement folks stop somebody's got fentanyl in the car. Like Dr. Crawford says, they're opiate naive, they breathe it, they get it, and then they have a reaction to it. So I think some of having the naloxone around is just a good thing to do, because you never know how you might stumble across fentanyl or an opiate today. And you need it handy. If you don't have it, you don't have it.
There was an interesting study done in North Carolina at one of the military bases that they were giving naloxone to people who are on chronic opioids. And even if the patients did not pick up the naloxone, because this was even before all this distribution was happening, but they actually found that it reduced the risk of overdose by just giving a prescription to an individual who was on chronic opioids. And the theory is that the clinician is making the person even more intensely aware that there is a risk to the medicine they're giving them for their chronic pain.
Mm-hmm.
Now that's a theory, and I don't know that the study's been repeated, but I thought it was a fascinating result that even if they didn't pick it up, there was a reduction in risk of overdose.
I think you're right, Lenore. I mean, I think, you know, it's hard for people to sometimes to, you know, get their mind around a harm reduction program. And we do that all the time with all other kinds of healthcare. I mean, you know, we do that with suntan lotion, we do that with seat belts, we do that with helmets. We go riding our bike, we do that with all kinds of things. And we don't really give that a second thought. But when it comes to some of these things that seem to be maybe morally charged, you know, we may have a different view of it. You know, gun locks are the same kind of thing. You know, I mean, put a gun lock on your handgun, put a gun lock on your on your shotgun or something, because plenty of kids are killed every year playing with loaded handguns. So you know I mean, that's harm reduction. So there's a lot of things we do in terms of seat belts for harm reduction. So
sometimes equate it with programs like in some of the major cities that they had needles that people could use that were sterile, you know, so that they could
Right. The needle exchange programs.
They kind of equate them all together, you know.
Yeah, those are, you know, those programs to me are I would say that those are a bit more controversial, the needle exchange, or even providing a place for addicts, people with substance use disorders to go and use their chosen drugs of abuse and then have attendance available in case they do. And I know that's happening in some areas, particularly I've heard of it in Europe. I don't know if there are many in the United States. I don't know that we have any in Oklahoma, but it's a chance to provide a safe environment that again allows the person to maybe eventually get into treatment. And because if if they do something that causes harm to themselves, then you may already be too late to help them.
That's a good point because, once you're using intravenous drugs and then, you have endocarditis or you develop some kind of infection,
Right.
The chances of trying to, deal with that plus the substance use, it just really gets complicated really fast. And endocarditis, is a direct result of intravenous drug use. Not all endocarditis, but effective endocarditis, where you're
Very high
using
incidence of
substances,
that.
high
right.
incidence of that. And then you're going to talk about a valve replacement, and it gets very costly, very quick, and it's very hard to manage when you have somebody who's that sick physically and has a substance use that caused it. So, yeah, I think it makes some sense. Any other comments or thoughts on either the OPIC material or program or on harm reduction?
I didn't know about that open program. That's good to know.
Well, if you know of practices and or primary care clinicians that you work with or know of that may be interested, just give them our name, or you can share the slides. I assume, Mike, you'll be providing
Sure,
the
we'll
slides
do it.
to them and be happy to talk with them. And we have, like I said, we have a big team that'll go out. We have folks that'll go out and talk with their practice if they're interested.
Yep.
In any of the three programs, in general, the SBIRT, the Do No Harm, or the we call it the OED, opioid education and naloxone distribution program.
The other thing I want to mention is, with the OPIC, they've got some guys who are really good at managing electronic medical records and helping practices get the most out of their electronic medical record and being able to put some of the screening instruments in an electronic medical record so that it's much easier to use. So I know that some particularly smaller practices may kind of struggle with really understanding their EMR system and how to get the most out of it. So that's one nice thing that the OPIC program has, is the ability to get some consultation on that. So,
And that people can just fill out their own evaluation while they're sitting in the waiting rooms.
Yep.
yeah.
Try to make it simple.
Yes. Okay, well, it's about 10 till, so we'll give you a few minutes back unless somebody else has a comment or a question or something we can help you with. This is a little different presentation, but we wanted to do it because we thought it was important, and I appreciate Dr. Crawford be willing to do it with me. But going one more time, any other thoughts?
Thank you, Dr. Brandon, Dr. Crawford.
Thank you. Thank you for
right.
attending, everyone, and nice to see everyone. At least your all's names on the
Yep.
attendee list.
So very good. So I hope everybody has a good holiday, a safe holiday, good Christmas, New Year's, and we will see you back on January the 6th, Friday, January the 6th. So take care. Thanks a lot.
See ya. See you, Mike.
Okay. Bye-bye.